Hi everyone! Competing directives in the two tiers of the work. Today I'm going to talk about competing clinical directives and the process of triaging or prioritizing. I'll speak to my personal North Star when it comes to psychotherapy, and I'll be discussing some real-life clinical examples today. Before I get to the examples, though, I'd like to set the stage with a brief preamble. If you think about it, this is what we do all the time in every single psychotherapy session. We're interpreting what's coming at us, and then based on various directives and principles, we respond and intervene accordingly. So knowing which way to go and which directive to adhere to and what part of the client's communication we should be focusing on is the key to having good outcomes. The when part, by the way, is really huge. When to do what. So to help us navigate this discussion, I will offer some structure by introducing two terms that I find helpful. Tier 1 and Tier 2. Tier 1 is where we're not actively trying to mobilize the client's unconscious through added pressure, but instead we get clear on their goals for therapy, we do a dynamic inquiry, we help the client see their own triangle of conflict, we help the client get clear on the therapeutic task, and we might make some triangle of person links. We establish a thematic framework where the client can begin to see the core themes around their triggers or what seems to precipitate their feelings, their core conflicts, and also around their own contributions to their own symptomatology, their own suffering. Here we might ask for feelings, but in the service of clarity. We just want to have a sense for to what extent the client is, say, aware of their feelings and impulses versus not aware. And then help the client see this about themselves. So though we might ask about feelings here at this stage, it's done conversationally and without the sense that we are applying a technique. In Tier 1, it's also where the corrective emotional experience tends to happen. Sometimes it happens when we move too quickly to Tier 2 and then realize that, and then we have to go back to Tier 1. That can also be where the corrective emotional experience takes place. So there is some pressure in Tier 1 just by virtue that we ask very personal questions and make observations and basically invite a close relationship. But at this stage, we don't stack pressures or go for a high rise of complex transference feelings to try to get an unlocking or anything. I might stay exclusively in Tier 1 with fragile clients or with clients with access to a heavier projective process or more regressive defenses. When clients are highly resistant right out of the gate and they're engaging a kind of malignancy that makes collaboration impossible, my head-on collisions are also conversational in this tier. Matter of fact, without added pressure, more of a, well, this is the situation we find ourselves in kind of a thing. So in Tier 1, we create a foundation for Tier 2 work. We might get smaller passages of feeling at this stage by horsing through low-level feelings and impulses, but this is done in the service of either capacity building and or strengthening the alliance and bringing more clarity to the link between avoidance and symptoms. And by the way, I just can't resist this. This one's for you, Eric. The horsing through only if it doesn't amount to an inordinate amount of effort on our part. So, one of the main desired outcomes from the Tier 1 work is that the client will have a truly experiential clarity on the therapeutic task. Not just taking your word for it, but experientially seeing that their symptoms are a result of avoidance. In Tier 2, we increase pressure with the aim of a partial or major unlocking, or at least a higher level passage of previously avoided psychic material to more fully restructure the defensive system. So here, pressures are often stacked. It becomes clear that we're truly applying a technique in this tier. Earlier, the work is conversational in style. Tier 2, it's unmistakable. We are using a technique. Sometimes we might go back and forth between the two different tiers, especially if we're doing capacity building and restructuring type work. It depends on the focus, but generally, when we get to tier 2, we don't really let up until the client either, goes over a threshold, and then we have to back off, or really has a breakthrough, has an unlocking of sorts. Some clinicians spend very little time on tier 1 and very quickly go into tier 2. If you have followed my work at all, though, you won't be surprised to learn that I tend to do the opposite of that. I have a fairly high standard for green lighting tier 2 work, meaning that I want to milk tier 1 for all I can get out of it and to make sure that I have a sufficiently strong foundation before I get to tier 2. Slower at first often translates to faster later, at least for me. Approaching my work this way has translated to very low dropout rates and overall solid results. So, for example, earlier in my career when I had lower standards for moving to tier 2, I had far more dropouts, and also I didn't enjoy my work as much as I do now. It was draining, and I stopped looking forward to seeing my clients. That's an important criteria, by the way. What helps you look forward to seeing your clients and do the work versus not so much? But that's a topic for another video. But, whatever gets the job done, right? We all find different approaches helpful. I'm just really speaking to what I have found to be the most helpful for me. So anyway, it might be helpful to keep these terms in mind as we go, tier 1 and tier 2. Recently, I had one of my lovely supervisees ask me how to know what to focus on when the client seems to relay a number of different important communications. What do you prioritize and go with? That was the question. In my trainee's case, it was a matter of helping them see that the client was discussing things related to the core themes of her struggles. The client spoke about her characteristic way of avoiding her feelings, and she alluded to what precipitated her feelings, identifying the core themes through thematic listening, and then feeding this back to the client in crystallized form is often a good way to go. And for those of you that may not know, I use the term crystallized the way Marvin did, which means taking the distilled essence of what the client is saying or doing and then reflecting it back to the client in a way that brings the material into bold, stark relief. This brings clarity and perspective. It ensures that the client understands herself or himself, ensures that we're understanding them because they have a chance to set us right if we got it wrong. And it goes a very long way in bolstering the conscious therapeutic alliance. So in the case that my supervisee was discussing, it was a matter of helping her see that she needed to create headers or umbrella categories for the client so that the things that the client was talking about or doing could get organized into a psychodynamic thematic framework. In concrete terms, this involved bringing clarity to the triangle of conflict and seeing the need to inquire into why the client associated having her anger exposed with catastrophe. Let's get to some other examples. Take Johnny, fabricated name, but an actual former client. In this one session, he had begun to turn a corner on his depression, so he wanted to focus on anxiety and a problematic relationship to food and eating at this point. We did an inquiry into the origins of the issue to see if we could clarify the cause and the themes connected to this particular problem. A significant amount of paranoia emerged, not in real time, but he was describing paranoia, a fear of being poisoned and so on. But then I noticed that I was learning useful things for sure, but he was avoiding eye contact and he didn't seem upset or alarmed about the content of what he was sharing, even though what he shared, the content, was torturous. I was still learning important things about him, right, and this issue, so I could have continued the inquiry into the food issue, but the avoidance of contact between us and his lackluster presentation took priority for me. So I opted for the directive to address barriers to and avoidance of contact with me rather than the directive that says that as long as we are learning psychodynamically significant information, don't interfere in that process. Keep going, right? That's what I opted for. Or the directive that if anxiety is too high, resulting in projections and paranoia, sometimes supporting the gaze avoidance is a way to go. But it was his level of gaze avoidance combined with the fact that he didn't seem anxious at all in real time. And he wasn't paranoid in real time. He was describing paranoia, but it wasn't really happening in real time. So that was the deciding factor for me in this case. But I also had to contend with the question of why he didn't seem alarmed about his torturous relationship to food and eating. Was he simply coming up with something for us to work on to avoid saying goodbye? He was, after all, turning a corner on his depression. So there are a number of factors to consider when we choose what to attend to at any given moment with our clients. Let me give some other examples in the hopes that I might really paint a proper picture for this idea of competing directives, how it shows up in our work, and then my way of navigating this reality. Take Carmen. That's a name I just made up as well, but I'm thinking of an actual client that I've worked with. So not only was this client from a culture where there were strong gendered associations and assumptions about men not being trustworthy, but Carmen also had a history where almost every male in her life had shown themselves not to be trustworthy. In addition, there was the association that closeness with a male making eye contact was connected to sexuality. Emotional closeness with a male without sex was pretty much a foreign concept to her. The client did not readily actually volunteer all of this information at first, but there were hints in her language that suggested mistrust. From a purely ego-adaptive capacity point of view, she seemed to be able to tolerate a standard format of ISTDP. There was strided signaling, sighing, isolation of affect, motivation to get better, insight into her resistances. It was all there. But here and there, she would say things that were part of the language of mistrust. There were signs of impression management, and there was also something about how she would look at me that just gave me pause. In a way, you could say that there were two competing directives here. I could go to what I spoke of earlier as tier 2 of the work and just begin to move towards higher levels of mobilization, towards an unlocking. Or I could go the path of exploring what seemed to be an underlying mistrust that was never really made explicit until I began to really inquire into it. Fortunately, I chose the latter, and it was confirmed that there really was this underlying mistrust, which was far deeper, by the way, than merely tactical, as the patient could see that I took the time to flesh out this part of her experience. She was greatly relieved, and she could begin to experience trust in a man, perhaps for the first time. So this paved the way for tier 2 work. In this case, the competing directives were to either stay longer in tier 1 and try to sort out something that seemed a bit off in spite of some evidence that she was ready to go for an unlocking, or to go for an unlocking through adhering to more pressure, tier 2. So if your prime directive, for example, is to always go for an unlocking, or at least as high of a rise as possible in the complex transference feelings, provided the capacity is there, you would have probably gone a different route than I did. But boy, am I relieved that I didn't do that, let me tell you. What I found was that the client was very relieved that I didn't, and the corrective emotional experience created a better foundation for tier 2 work. Another case, I'll refer to him as Jordan, though that's not the real name, it's a fictional name. So with Jordan, it became clear that I was dealing with some fairly egocentric defenses. Vagueness presented itself early on as the major column. The main thing the client was habitually and defensively engaging in that was preventing progress. When I say major column of defense, that's what I mean. So we turned a corner on the vagueness fairly quickly, and then surprise, surprise, another defense crops up, right? And this defensive maneuver, it took the form of the patient competing with me, of doing both parts of the relationship, of getting ahead of the process because of his knowledge of ISTDP. I pointed this out and tried to turn him against this defense, but our work stalled. It didn't really take. So here I had a choice. I could bear down on this defensive maneuver and not budge, just insist on trying to get him to turn against it, or I could give the patient some latitude with this defense and observe the results. I chose the latter, and it became clear that somehow this allowed us to begin to progress again. The client would access more feelings, he would feel seen and understood by me, and there was movement again in our work. We were getting to deeper feelings, and there was a strong emotional bond between us. It became clear that not being perfectionistic about this defense was important for our work. I'm speculating here, but my sense was that few things had ever been on the patient's terms before. And so it was therapeutic for him to see that in our relationship, I could tolerate things happening on his terms. Had this resulted in the halting of the therapeutic movement, of course, I would have taken a different approach and really gone for the obsessional and the competitive dynamics, defensive maneuvers. So the key deciding factor is as always, right, it's response to intervention. And the competing directives here involved either a more strict approach to defenses, where I would just not relent on trying to turn him against those defenses, or a more lenient approach that ultimately provided movement. Could I have gotten greater gains had I gone with the first directive? It's certainly possible. But I might have also gotten a misalliance. Speaking of directives, my personal prime directive is to be immediately and experientially connected to what's going on inside of me and my client in real time. If other directives help me accomplish this, I go with them. And if they do not, I shelve them. So all the examples I mentioned today were guided by my prime directive. Sometimes I need to stay at a tier 1 phase in order to accomplish my prime directive, and at other times I need to ramp up pressure and or confrontations and move to tier 2 in order to accomplish the directive. But allowing this prime directive to be my North Star has dramatically increased my enjoyment with doing this work and seeing my clients. Like, I wake up and I look forward to seeing all of them at this phase in my career. That wasn't always the case. I no longer feel like I'm trying to drag my clients up a hill. I'm no longer exhausted after a 3 or 4 hour session. Falling in love with my clients is now the norm, not the exception. Bracketing off, obviously not in a romantic way. If my work looks like classic ISTDP, great. If not, also great. I could care less. I only care about helping my clients, and adhering to my prime directive is what seems to help me do that the most. That will be all for now. Thank you for watching. Till next time.